Hi guys, I just want to reiterate Jessica's comments and welcome everyone on the line tonight. I'm hoping, and I have the goal of, as we go through this presentation, that I'll be able to help you in better understanding some of these clinical commonalities and actually how these can better help you interpret the micronutrient profile. One of the things that when you initially, and I think we all pretty much go through this evolution when we start looking at the micronutrient testing, our inherent kind of flow on this is for us to start looking at these individual nutrients and try to get a real handle on these individual nutrients. And I think that's a good process because it allows us to have a better understanding of how these nutrients begin to fit into different biochemical pathways and what they actually mean on an individual level. But you know, as you begin to see more of these, you begin to notice some clinical corollaries between them, and it's these clinical corollaries, you see in these nutrients and how they work together and how these deficiency patterns begin to associate with each other that really allow you to start to get the most out of the test. So having said that and looking at where our discussion is going to go tonight, I want to kind of highlight a few points that we're going to talk about through our discussion. And the first one here being the benefit of looking at these clinical patterns over individual nutrients. Now, with that said, I want to not dispel or not discourage to look at these individual nutrients because they certainly have a role as well. But I want to highlight again the attribute of looking at these nutrients in a pattern-oriented manner. Certainly, if you're looking at some of these patterns, we want to understand or we want to not just understand, but know what some of the more common deficiency patterns are. One of the things I think that's important to know about this, and I like to highlight these few that we're going to talk about tonight, because in looking at these patterns, if you have a good mastery and understanding of these patterns, you'll be able to help a large portion of the patients that are going to present to your clinic, because the patterns seem to present themselves on a fairly repetitive basis. So there's a couple of core patterns that we really need to try to understand, and we'll review those in good detail tonight. We'll look at how to target some of your interventions, so looking at these not just simply from the standpoint of nutrient repletion, but also looking at it from the aspect of how do you make recommendations that may not necessarily be nutrient repletions or nutrients that would show up deficient on the test, but other potential, whether it's supplements or lifestyle recommendations that may be of benefit to the patient as well. And again, just looking at these recommendations beyond individual nutrients here. And then one of the points that I feel like is probably most beneficial in having a tool like the micronutrient test is being able to utilize these patterns to predict the degree of dysfunction and some of these long-term outcomes for the patients. So when we look at this test, one of the things that we want to be able to impart to the patient is not so much just the fact that there's a deficiency there and that, yes, we need to correct the deficiency, because that is clearly important, but we also want to impart the knowledge to the patient that there are consequences to these deficiencies remaining, or to the body remaining in a state of multiple deficiencies. And we really know now that without correcting some of these deficiencies, the progression of some of these states of dysfunction and maybe even moving on and beginning to be characterized of disease states is going to progress without correction of these deficiencies. So we certainly want to take note of that, and we want to highlight those aspects for our patient population. And we'll talk about what some of the more common ones are and some of the talking points you can use with your patients. Now, I want to get into right away looking at the benefits of these clinical patterns, but to do that, we really have to differentiate the process of utilizing patterns as compared to the process of looking at individual nutrients and even looking at pairs of nutrients and thinking about imbalances. So the three predominant ways you can look at it and begin to interpret the test is, one, you're going to be able to look at single nutrients. So, and again, that's just what that is. You're focusing on a single nutrient. You're looking at that nutrient in isolation, and we're kind of thinking about whether it's a sufficient status or a deficient status, and where that nutrient is, and maybe how deficient that patient is in that particular nutrient. From there, the next step forward would be to look at pairs of nutrients. And here what you're looking at is you're looking at these nutrients that we tend to think about as being synergistic. So whether we're talking about B12 and folate, zinc and vitamin A, selenium, vitamin E, these types of things, these types of pairings, what we're looking at is how those two nutrients interact with each other. So supplementing one or supplementing another, and how does that particular nutrient affect the other nutrient is what we're really thinking about with this. And then lastly, looking at these patterns, and with a pattern, really what we're talking about here is you may look at two nutrients here, but most of the time with this, you're going to be looking at more than two nutrients to try to fully have a better understanding of that pattern that we're going to think about, and trying to understand what that pattern of deficiencies or what the state of dysfunction is surrounding that pattern of deficiencies. Now, just to try to delve a little bit deeper into this, looking at these individual nutrients here, there's certainly some pros and cons in looking at an individual nutrient. So let me highlight some of the strengths in looking at these individual nutrients, because I think in understanding these strengths, it gives us a better understanding of what some of the weaknesses are for these nutrients. So with regards to the strength, it provides us a starting point. So it allows us to narrow down where our focus should be centered at in terms of what the primary dysfunction is that's causing the patient's symptoms to present. So let me give you an example on this. Let's say you've got an individual that has a state of fatigue, and we'll certainly talk more about this a little bit later on. Well, if you've got an individual with a state of fatigue and their micronutrient profile shows that they have a B12 deficiency, then you can begin to narrow down that state of fatigue for them is probably going to be impacted by lack of good, healthy red blood cell formation. So it's, and kind of things you can begin to roll out with this is you're not thinking mitochondrial dysfunction at this point. You're not thinking any type of abnormal handling of blood sugar, any type of dysglycemia. There are other nutrients that would point you more towards those being primary considerations for a fatigue state. But really looking at an individual nutrient begins to narrow what your area of concern is for the patient. So it begins to shorten that differential list that you want to begin to think through. It gives you some estimated time on the repletion. So you can just think about this in a logical manner, that the more deficient the nutrient is, the likely the more time it's going to take to correct that nutrient. You can begin to think about that in terms of how you're going to set your dosing. Does your dosing for that individual nutrient need to be a little bit more aggressive? And you can even do that within the context of looking at a pattern as well, and saying that if that nutrient is deficient but yet it's still part of a pattern, maybe I need to be a little bit more aggressive with trying to replete an individual nutrient as part of a combination of nutrients that I'll be using. It gives the patient feedback. I think this is an important aspect to consider as well, because obviously when we're looking at patient management, we have to get the patients to understand why they need to follow through with the recommendations that we're making for them. So when we look at these individual nutrients and we begin to see how severely deficient someone is, then it speaks more to them. It speaks louder to them that they need to be proactive and take more action on their follow-through on the recommendations that you're making for them. And in some scenarios, you have limited nutrient-nutrient interactions. A great example of this would be something like glutamine. Glutamine doesn't typically, when utilized in high dosages, you don't really see any other nutrient deficiencies begin to manifest as a result of using that in higher dosages with any consistency there. So you just don't have that same inherent concern with it. Now, just as you've got the strengths, you've also got the weaknesses here. So with these weaknesses, one of the things that we think about right off the bat is that nutrients often act synergistically. So, and I'll show you some great diagrams of this as we go through the presentation, but when we think about a nutrient, we don't typically think about that nutrient as a single point in a metabolic pathway. Usually you're going to have multiple nutrients that are involved in a metabolic pathway. So nutrients rarely act individual or in an individual manner. They're typically acting as a collective. You don't get any direct correlation to a specific system, so it doesn't really help you define the cause. I'll show you a great example of that coming up. But you really want to be able to help define where that cause is coming from, because again, that narrows down what your intervention strategies are going to be. And then just to the point earlier about nutrients being synergistic, just as these nutrients are synergistic, that means that you're more likely to run into nutrient-nutrient interactions if you're only focusing on an individual nutrient. So if you're giving a high dose of one nutrient over time, you're likely to create deficiencies in some of the downstream nutrients involved in those metabolic pathways. So certainly we want to make some considerations for that. Now that said, and looking at just kind of looking at how we can utilize individual nutrients and some of their strengths, chromium is probably a great example of this. It's probably one of the better stated examples, because for the most part, when we're looking at chromium and we're looking at what its most predominant role in the body is, it's going to be for glucose regulation and increasing the sensitivity of the insulin receptor. So, just as highlighted in this diagram here, where you're getting uptake of chromium through the chromium channels, and then you're basically in turn utilizing that chromium to activate the insulin receptor, such that insulin receptor can then in turn receive that insulin and begin to promote that secondary or that second messenger response over to the glucose receptor. So, it's certainly important to look at these nutrients and consider their role in a individual state, but we don't want to limit our thought process to that. And probably one of the nutrients that I can best give you as an example of that is going to be vitamin D. There's been so much information put out within the last decade about the roles of vitamin D and how many different things that it can do, that it does in the body. And I put this diagram up here as an example just to illustrate how many different areas and how many different roles vitamin D is actually involved in the body. I mean, you can see in terms of looking at calcium regulation and increasing calcium uptake from the gastrointestinal tract through formation of these calcium-binding proteins, glucose regulation, immune system function, proper cell differentiation. There's numerous different mechanisms where vitamin D is involved at, and when we're looking at the reports and if we only see that vitamin D is deficient and we don't consider what other nutrients are being affected as well, what other nutrients are trending into a marginal or into an overt deficiency as well to help establish that overall pattern, then we really don't know where our focus should be. We really don't know how to hone in our treatment protocols. We can say, yes, we can recommend vitamin D and we can replete the vitamin D status, but it doesn't give us any idea about really what else we need to be, what are the recommendations we need to make to the patient, because our recommendations aren't going to be just from a nutrient standpoint. We also want to look at what type of lifestyle, what type of dietary recommendations can we make, what kind of, looking at this from a full wellness or functional medicine aspect. We've got to help that patient address all aspects of their life. So only looking at these nutrients in a very isolated manner doesn't help us do that. So it really doesn't give us any guidance into the primary concern when only looking at that individual nutrient. Now, that's looking at individual nutrients, and now we can go one step above that and we can look at these nutrient imbalances. So again, for the most part here, we're beginning to think about two different nutrients having a role, and this is best going to be identified with some of these synergistic nutrients, and I gave you some example of these a little earlier, and we'll repeat these. Your B12 and folate, that's probably one of the more common ones. And just to kind of more fully explain how that begins to manifest and why looking at those two nutrients together is necessary, this really comes down to if you find a deficiency in one and you begin to replete that deficiency and you don't give at least some consideration and compensation for folate in this scenario, then you would be looking at the potential progression of a megaloblastic anemia. So we certainly don't want to create a state of dysfunction by trying to replete a nutrient. We're looking to try to optimize the overall nutrient repletions or the overall nutrient status for the patient. So we certainly do want to keep these into consideration, but we don't want to just stop our thought process with this. Now, some of the things that you're going to want to consider with your synergistic nutrients here is that they do provide better insight than the single nutrients do, but they're limited in their ability to completely help you define where that dysfunction is in the overall state of physiology in the patient. So that's really what we're trying to dissect and decipher out of the testing is where is that dysfunction at, and how is my protocol that I'm going to set up for this patient going to best support that state of dysfunction. But it's less ideal than looking at the overall patterns. So we really want to focus on these patterns. So with that said, let's begin to talk about these. Now, when you're looking at these deficiency patterns, one of the things that you want to do, and one of the things I think helps, and you can actually get this information from looking at the cover page on the test. That report that comes back, looking at that cover page, you can just simply see, and it makes a statement to the patient as well, that the more deficiencies they have, the more proactive they need to be about their health, and likely the worse their state of health is. So we certainly want to just look at that pattern, not necessarily trying to make correlations within the pattern, but just looking at it as a whole and how many deficiencies there are and how aggressive you need to be with that patient to help them restore those deficiencies. Looking at the deficiencies, one of the attributes here is that you're taking all of these nutrients into consideration. So you're trying to, when you're talking with a patient and a patient, they come in for their initial visit with you and they're giving you some feedback on giving you their history and telling you what their signs and symptoms are and what their areas of need are, you really want to take everything in. And when we get these reports back, you sit down with the patient, you order the report, looking at all these nutrients together begins to help you tie in some of these loose ends that the patient may be complaining about. Some of these symptoms that you're thinking, well, gosh, I don't really know how that's related to their primary complaint, but now you look at these micronutrient reports in their totality, and it may answer some of those questions for you. And of course, it begins to narrow the focus on where support should be centered at. Now, some of the considerations we want to make with looking at these patterns, I recommend starting with the patterns that are already established for you on the reports themselves. So when we look at that, when we look at these groupings, you're going to see that the initial grouping in the graph section is going to be your B vitamins. From there, you're going to move into your amino acids and metabolites. And just to kind of think about this for a minute here, when you're looking at these B vitamins, if you see that you've got multiple B vitamin deficiencies, your thought process automatically begins to shift in one manner as compared to another. Same thing with amino acids. If you see multiple amino acids are deficient, you're beginning to think that there might be some limited intake of protein in the diet. There might be some impairment of digestion, potentially assimilation of some of these proteins. So just looking at the groupings that are already established for us begins to give us information about the overall state of the patient. Just to go a little further with that, the other vitamins and minerals section, the carbohydrate metabolism section, and then certainly looking at the Spectrox marker and additionally looking at the individual antioxidants, you can extrapolate from just those groupings that the more deficiencies you see within those categories, the likely the higher state of inflammation is for that particular individual. So it gives you an idea of, at least in part, where your starting points are going to be. Now, you can go beyond the information that the test supplies for you inherently and begin to break things down into, say, water-soluble nutrients, your fat-soluble nutrients, the nutrients that might be more affected, again, as a part of an inflammatory state, nutrients that are associated with cell membrane integrity. So, I mean, there's a lot of different ways to begin to break these characteristics of nutrients down, but what you'll begin to see is as you begin to think in those types, in that type of fashion and think about things in that format, you'll begin to be able to see where the patient needs the support at, and it will allow you to begin to target your intervention strategies with the patient. Now, one of the things that I recommend you do is, and you see this in the graphs, you'll see with the graphs you've got the white region, the yellow region, and the blue region, and that yellow region is one that sometimes it can seem a little bit easy to overlook that section of the graph sometimes and think that, well, this patient doesn't have an overt deficiency here, so maybe I don't need to be quite as worried about that. about that nutrient. I would challenge you not to think in that format. I would recommend that when you get your reports back and you're looking at your cover page, if your cover page only shows that it only shows the overt deficiencies that the patient has, request that the reports also have the marginal deficiencies printed on those as well. And there's a couple of key points and a couple of key reasons that you want these on here. One is these marginal deficiencies are needed to help you begin to be able to complete these patterns. So when we're looking at trying to utilize these different nutrients and thinking about, okay, I've got a portion of nutrients over here that have an overt deficiency, but now some of these, I'm seeing a few that would complete this pattern that are marginal deficiencies. That's a takeaway point. You want to utilize both overt and marginal deficiencies to help you establish a pattern. Don't just rely on the overt deficiencies. Now, it's important also to look at or to ask, what is it that a marginal deficiency is actually telling me? What is that piece of information suggesting? And what it's suggesting is that that nutrient is being utilized at a higher rate than is considered ideal. So you can think about this, I tend to think about this in regards to supply and demand. And what this is saying is that there is a higher demand for that nutrient than the body is able to keep up with. So you're not either getting enough in through the diet or even maybe through diet and supplementation to continue to meet the demands for that particular nutrient. And what we're seeing is that you're losing ground from an intracellular level, that the body is utilizing that nutrient at a higher rate intracellularly than what the supply is to keep up with that, to keep that level of balance. So just think about it as demand. And what's important about this is if that nutrient is left unsupported, it will in time become an overt deficiency. So this is why you rarely want to sit on a marginal deficiency. You generally want to take action on those, especially if you're seeing them trend more towards that overt deficiency state. So let me go a little bit further into this idea of deficiencies and increased nutrient demand. And the reason I want to do this is because in having the opportunity to look at these tests very frequently and working with this over the years with my patients, one of the things that I've come to realize with this is that for the most part, the reason that individuals develop nutrient deficiencies is because they're placing increased demands on their body. And I begin to think a little more about that, and it makes sense when we put that in the context of states of dysfunction. When our bodies move into a state of dysfunction, regardless of how that state of dysfunction was imposed, when they begin to do that, there are certain nutrients that are required at a higher rate to try to offset that state of dysfunction. It's only when we get to the point where the dysfunction is progressed to the point that it's utilized up the nutrient that the body can't keep up, and we begin to develop symptoms because now intracellularly we're not functioning at an adequate rate any longer. So again, these deficiencies, and you can get patients that certainly they're going to come in because their supply of a nutrient, their ingestion, uptake of a particular nutrient is not going to be adequate. But for the most part, think about these in regards to demand. So it's a higher activity of these metabolic pathways that's demanding the nutrient that has become deficient. You can think about this as it relates to supplementation too, because this is one of those things that's going to help you scale where your dosing on your supplementation is going to be. So an individual that is placing a higher demand on, and I'll just pick an arbitrary nutrient here, an individual that's placing a higher demand on B5 is not going to benefit from the same dosing. So that individual, as opposed to using, say, 250 milligrams of panthenate, that individual, or pantothenic acid, that individual may better benefit from 750 up to a gram of pantothenic acid. It just really depends on what their needs and demands are, and the further into that deficiency state they are, the more aggressive you're going to want to be to help them pull out of that deficiency state. And certainly you want to look at this because with these demands, it's going to, looking at the test as a whole will help you begin to decipher where some of their demands are coming from. Is it diet? Like I mentioned, if you the amino acids section mentioned a little bit earlier, if you saw multiple deficiencies in amino acids and maybe you saw a B12, a zinc, and a selenium with that, now you're beginning to think this patient may not be getting adequate protein into their diet. You can think about certainly forms of supplementation. Maybe they're not getting the appropriate form, so maybe the micronutrient test looks at folate. So are they taking folic acid over folate, and do they have some limitations there in helping them process that? Lifestyle and exercise. Exercise is we don't typically think about exercise in this manner, but exercise imposes demands on our body. And we benefit from those demands that are imposed to a point, but once we exceed that point, now we're beginning to place undue stress on our body, and that stress has to be compensated for through the action of some of these nutrients to try to continue to maintain the activity of these different metabolic pathways. So there's a balance point there, but exercise is one that you'll see that will place undue demands as well. So in short, what you want to do is you want to ask, where's the physiologic demand on the body that is placing a higher need for a particular nutrient or for a group of nutrients? And again, your patterns help you better answer that question. So with that said, let's begin to look at how do we establish these patterns, and then we'll move into we'll move into the more common patterns and how to better understand these patterns. We'll get into some good detail on these. So with trying to establish the pattern, the first thing we want to do is, what is the patient's primary complaint? Because again, we always want to put the test results in the context of what the patient's complaining about, what their symptoms are. So the first thing we want to do to help narrow our list is, what's that patient's primary complaint? And then we want to begin to think of nutrients that are characteristically associated with the patient's complaint. So, if I've got someone who has some type of gastrointestinal dysfunction, then and I see a glutamine, that's a natural correlation for me. But if I've got someone with blood sugar issues and I see that glutamine, then I'm not quite as inclined to utilize that glutamine as a first-line intervention. Glutamine is probably going to have a role in that treatment protocol somewhere, just because that patient would have a deficient state. But I want to, again, keep this in the context of the patient, keep this in the context of what their original complaints were coming in the door. Now, with that list of nutrients that you begin to narrow down in your head, so again, associating with the patient complaint, do any of those nutrients show up on the report? And if they show up on the report, it tells you exactly where to go with the patient, what your protocol should be. And then you're able to begin to narrow down your differential list. So again, I always tend to like the example of fatigue, because when we think about fatigue, there's so many different causes for fatigue. I mean, that list is extremely large. So when you look at the testing, that list begins to narrow down very quickly as to where your thought process and your intervention strategies are going to be. So in looking at mastering the most common deficiency patterns here, I want to show you a tool that you have at your disposal. And this is a piece of marketing material that SpectraCell offers. So, certainly if you make contact with the lab, make contact with your representative, they'll get this piece of information, this piece of marketing material for you. But where I find this is really handy is it gives you some of the different states of dysfunction that we tend to frequently talk about within functional medicine, and topics that are fairly common. So we want to have an idea of where our starting point. So when you're trying to map out in your head and look at, well, how do I establish these deficiencies, and what does this deficiency pattern tell me? This is a good cheat sheet for you. And it's you can see here's an extenuation of that. So a couple of other things, certainly things like inflammatory disease, given how rampant inflammation is within our society. Just thinking about the number of patients that come in complaining about insomnia and inability to sleep through the night, and of course thyroid and weight management and stress. Those are always big topics for patients, feeling like those might be underlying some of their complaints. So this is a tool that you can have that is at your disposal, so take full advantage of this. Now, I want to, in looking at this tool, I want to start with the diabetes pattern. And the reason I want to start with the diabetes pattern is a state of dysglycemia, as long as it remains present, you've always got dysfunction in the body, and it's reaching its tentacles into other areas in the body. So, and here's a good example of that. You can think about, as long as dysglycemia is present, you're also going to have some additional degree of endocrine dysfunction. Some of the steroid hormones, the cortisol acting as a glucocorticoid, and maybe even acting in some of its anti-inflammatory roles, are going to be challenged here. So this is a pattern that you really want to have a firm handle on. And fortunately, when we look at the reports, we've almost got a little bit of a cheat section on this in looking at the carbohydrate metabolism section. But I don't want us to just zero in on that area and only stay isolated to that area. We want to think outside of that region as well. And we'll talk about both the carbohydrate metabolism section as well as the others. Now, when we're talking about this dysglycemic pattern leading us potentially, if left, to progress on towards diabetes, we're really talking about the continuum that begins from normal blood sugar and moves into a hypoglycemic state, and then on towards insulin resistance, and maybe if you classify pre-diabetes in there, ultimately to that disease state of diabetes. So it's really throughout that continuum. And the more nutrient deficiencies that are present within these patterns, within this dysglycemic pattern, generally the worse the state of dysfunction is going to be. And that's a pretty logical correlation, and it just makes sense that the more deficiencies you have, the more impaired the cellular machine is going to be, and the less ability there is for the cells to carry out what is considered a normal, ideal role for them. If they can't carry out that role, they begin to slip further into a disease state. So the more deficiencies you see, again, there's to some degree a linear correlation with this. The more deficiencies, the worse the disease state. So we want to take action on these. So, just thinking about this, the prognosis is worse if these deficiencies are left uncorrected. So, and I'll show you where we've got some great literature references on this that we can really stand on to follow through with that statement and making that point to our patients. Now, looking at this next slide, one of the things that we do with regards to diabetes is, if we were to think about, if I asked you, tell me, characterize diabetes for me, the first things you're going to say to me are probably elevation in blood glucose levels, elevation in serum insulin, an elevation in hemoglobin A1C, some type of chronic inflammatory response as a result of that. There's a number of things that we begin to think about with regards to a number of characteristics that we think about when we talk in terms of diabetes. But look at what this study, how this study actually positioned and characterized diabetes, because it's looking specifically at micronutrient status within these individuals. And what this goes on to say is that type 2 diabetes is characterized by significant losses of important micronutrients. So, just as we think about the blood sugar, the insulin, the HbA1c, the concurrent inflammation, our thought process should immediately begin to also characterize nutrient deficiencies as being tied into type 2 diabetes as well. So we don't want to ignore that aspect of it either. Now, interestingly stated in this particular study, the less well-known micronutrients, I would imagine for most of us that are on the line listening, things like zinc, magnesium, chromium, vanadium, these are going to be things that we characteristically think about with looking at a dysglycemic state and progressively into that diabetes state. But also you've got these other categories of nutrients in here, your copper, your manganese, selenium, and specifically I wanted to touch on these groups, these certain antioxidants, because this is a category that we can see within the micronutrient profile as well by being able to look at not just the individual antioxidants, but also being able to look at that Spectrox marker. So when we think about diabetes in the context and insulin and elevated serum and insulin, and thinking about those in the context of being glucotoxic and insulinotoxic and creating these inflammatory states, those inflammatory states are what's going to decrease our antioxidant status. So if we look at that spectrox and we see that that antioxidant status is decreasing, it gives us some indication within that dysglycemic pattern of how much dysfunction is occurring and how much damage is occurring in some of these small vascular areas in other regions of the body. So, you know, certainly we want to, again, I think the takeaway point I want you to walk away from this slide is the characterization of type 2 diabetes as being significant loss of some of the important micronutrients. Now, when you look at this, what makes up a diabetes pattern? Well, within your carbohydrate metabolism section, you've got the glucose-insulin interaction, you've got chromium, you've got your fructose sensitivity, and then outside of that, some of the nutrients that tend to present more consistently are going to be zinc, magnesium, vitamin D, B3, and manganese. So what I want to do from this point is I want to take each one of these and give you more background and show you how and why these nutrients fit into these patterns. So when you see them, you'll have a real firm understanding of biochemically what's occurring with these patients. Now, when we talk about glucose and insulin, I mean, those are just obviously part of the diabetes conversation, the dysglycemic conversation. When we talk about these things, what we're essentially doing is, this is what goes through our head. We look at glucose and we think, okay, glucose, it's a monosaccharide, primary energy source, it's not getting into the cells, it's not being uptaken into the cellular machinery. Then we go on to insulin and we say, okay, insulin is a peptide hormone, and insulin is what's going to be needed to stimulate the insulin receptor, to stimulate that second messenger system to go over and tell glucose, or to tell the GLUT receptors to open up and be able to take up the glucose. So we have this very extracellular thought process, if you will, on what the sensitivity of the insulin receptors are. So, you know, we look at glucose and we look at insulin, and we tend to think about the higher those are, the worse the state of insulin resistance is going to be. So we're not actually looking at the insulin receptor in any way in this. We're just looking at elevations in these extracellular molecules. So it would be able to be of benefit to us to now, in turn, look at these things from an intracellular standpoint, and we can actually do that through the utilization of the glucose-insulin interaction marker. So this is not a guess, if you will, to say that, well, glucose is elevating, and, you know, as a result, we tend to think about insulin receptors probably not being as adequate as they need to be, or maybe if the insulin's elevated, the insulin receptor is not as sensitive as I would like to see it. And those are good extrapolation points, but they're still extrapolation. So it would be better if we have a direct measurement to be able to see how sensitive that insulin receptor actually is at taking up glucose into the body, and that's what we're able to better define through this glucose-insulin interaction marker. What that looks like for us in terms of getting the reports back is, and these are two examples here. You've got on the left, you've got your deficient glucose-insulin interaction, and what you're actually seeing is that this is an impairment of the ability of the cell to uptake glucose. And I wanted to put these diagrams on here with both glucose-insulin interaction and chromium just to draw and again, most of us know this. This is not a novel statement, but just to draw the connection between those two, between that nutrient and the insulin receptor and the uptake of glucose here, that you can see. And think about this in the diagram on the left side here. You note in this that the glucose-insulin interaction is marginally deficient, but it's still marginally deficient. So this patient has already begun to have impairment of their ability to uptake glucose, or uptake glucose into the cell through stimulation on the insulin receptor. Also note here that chromium is overtly deficient. Chromium has already moved into an overtly deficient state. So if that chromium level, and understanding that chromium is so directly tied to the glucose, or to the insulin receptor to support that glucose-insulin interaction, if we don't support that chromium, if it's left untreated, the only direction that glucose-insulin interaction can go is further into a deficient state. Now, let me contrast that with sufficient glucose-insulin interaction. And you'll note in this patient that on the right side of the slide here, you'll note that this individual has a higher chromium status, and you're also seeing a concurrent adequate glucose-insulin interaction status as well. So it just stands to reason that the better we can keep that chromium status, the better you're going to see that glucose-insulin interaction. So those two are intimately tied together. And this is a slide that just goes a little further into that, just kind of diagramming some of what I said earlier, and seeing that you've got the insulin receptors here, and they're responding adequately to the insulin through the action of, or through the glucose tolerance factor, which is made up by predominantly chromium, but you also get some B3 in here. Now, thinking outside of the box for just a minute here, we tend to always think about these things in terms of adequate insulin receptor sensitivity is going to be tied into these GLUT receptors, and as a result, we're going to get uptake of glucose into the cell to be in turn utilized through our energy production pathways, through glycolysis, Krebs, and on through the electron transport. But look also that insulin, and this is moving away from the interaction of insulin of the glucose, but look at also how insulin is associated directly with gene expression and growth regulation. So, we don't want to forget those attributes either, and those are things that chromium and as well, and I'll show you some examples on this in a minute with B3, but these are things that chromium and B3 do for us as well. So we want to think about these two nutrients together. Now, just as a sidebar on this, we also want to note that if the glucose-insulin interaction is insufficient and glucose tolerance factor isn't doing its role, then we're going to see that there's excess glucose that stays in the bloodstream, which in turn leads us to our advanced glycation end products. So looking at that sugar glycating some of these various proteins throughout the body, and then your triglyceride elevation as an additional result of that. Tying B3 into this as well, I think this study does a great job of really saying a lot for us, and it's looking at the role of chromium in the glucose tolerance factor, but note that this mentions that the glucose tolerance factor is a complex of both chromium and nicotinic acid. And what was important in this is the results, the outcome here, and it's that the data suggests that the inability to respond to chromium supplementation may result from suboptimal levels of dietary nicotinic acid. So when you look at your patterns in this and you're trying to help establish the pattern, think of it this way: if you see a deficient chromium, you know there's impairment of the glucose tolerance factor. If you see a deficient chromium and a marginal or overtly deficient B3 as an additional marker, just know that the impairment on that glucose tolerance factor and in turn on those insulin receptors is even worse. So you would want to be even more proactive about that. So look for both of those markers. Now, lastly, in that section for carbohydrate metabolism, we want to look at fructose insensitivity. This is a marker that can initially present as a little bit of confusion, because what we're actually saying when we look at fructose insensitivity is fructose intolerance. So it's an impairment in the ability of fructose to be metabolized efficiently, and what's happening here is that as that fructose is being taken in, there's an increased burden of fructose in the body, and what that subsequently does is it overwhelms these outer-lace enzymes such that those outer-lace enzymes can't keep up with the demand to continue to produce this fructose 1-phosphate. So you can think about this as you're literally bogging down this fructose pathway. And what that does in time is, as that pathway begins to become bogged down, as the outer lace enzymes can't keep up with that demand, you're inhibiting these substrates that move over into glycolysis. You're inhibiting those substrates from moving into the glycolytic pathways. So you're just not fueling those energy production pathways as readily as would be considered ideal. Some of the things that tend to exacerbate this, you'll run into individuals sometimes that tend to consume a lot of fruit. Maybe they're an individual that does a lot of juicing. This is something you'll see with them sometimes. They'll have a great spectrox status because they get all the antioxidants from their juicing, but their ability to metabolize that fructose is impaired just because they're consuming so much fructose that their body can't handle it. And then certainly you see this with the consumption, any type of routine consumption of high fructose corn syrup. Most of us know the damaging effects there. And then some of your interventions on this will be just predominantly remove the offending food. Give the body, give these enzymes time to catch back up with this process. And you can look at some of the additional lab markers to help you better define how much effect this is having if you're seeing elevations in the triglycerides, elevations in uric acid, this type of thing. This is actually going to be a diagram of what I was referring to. So you'll see in this diagram where you've got fructose, and you got that as a result of your fructose consumption, and then that fructose has to be shuttled over to the liver, such to the point that the fructokinase, which is going to be only found in your liver, can begin to act on that and take that and make that fructose 1-phosphate from that, such that your autolase can then turn it and make that your dihydroxyacetone phosphate and your glyceraldehyde here, such that those can be shuttled into glycolysis. But what this fructose insensitivity is really boiling down to for you from a clinical standpoint is that that individual has got to reduce the fructose substrates in their diet. They've got to cut the amount of fructose back that they're consuming on a repetitive basis. Now let's start working outside of the carbohydrate metabolism, and these are nutrients that when you start looking for these, you're going to consistently see that these will be deficient. And zinc is one of the ones that is probably more consistently marginally deficient to help you establish this pattern. And just look at the different roles where zinc is established in the glucose regulation. So from synthesis, storage, release, even acting in an antioxidant role to inhibit beta cell function or to inhibit beta cell damage in the pancreas. There's numerous roles where zinc has a place here. But probably one of the most important is if you look at the structure that I've highlighted here on the right side of the page or right side of the slide, what you're seeing in the center, that purple section there, that is actually zinc holding these 6 different structures of insulin together. So when you see, the way you can think about this is that when someone starts showing low levels of zinc on their report, they have literally gotten to the point where they're having difficulty continuing to produce insulin to be able to keep up with the demand to control blood sugar. So that's an important aspect in thinking about some of the dynamics of blood sugar regulation. Certainly magnesium has a role in here. Magnesium is easily lost just in general, but it's certainly lost at a greater rate when we're talking about a dysglycemic state. And there's a couple of reasons that happens. One of the things you're looking at here is that you're going to get just in general altered metabolism. You'll get poor glycemic control, and certainly the osmotic diuresis, so literally changing the osmotic dynamics in the body, and that's going to be associated with this microalbuminuria. But if you look at this statement down at the bottom, you'll begin to see literally where this magnesium is having a role here. So just look at this statement. It's saying for us that these decreased levels of trace elements can cause disturbances in glucose transport. So now think back to that diagram I gave you a couple slides ago where you're getting glucose in through that GLUT receptor. Magnesium has some effect on changing the dynamics of movement of glucose through that GLUT receptor, which in turn is what we're also referring to a little higher up in the slide here about poor glycemic control and these aspects of osmotic diuresis here. And then it goes on to say that you get insufficient formation and secretion of insulin by the pancreas, so magnesium has a direct role in that as well. So just kind of looking at 2 different factors here. To help you clinically put this in perspective and think about these markers from not just a diagnostic standpoint but also from a predictive nature, look at the findings in this study where it says intake of magnesium was particularly beneficial in offsetting the risk of developing diabetes. So what this says is that magnesium helps prevent a pre-diabetic from moving into a diabetic state. That's a pretty profound statement. And you'll also see in the slide you've got a couple of markers for your HbA1c and kind of what some of the guidelines for HbA1c are. Now, something that is not stated in these slides and an additional mechanism that you can think about for magnesium as well is that the telomeres, which SpectraCell also tests, those telomeres, the shorter those telomeres become, those caps on the chromosomes there, our genetic material, the shorter those telomeres become, the worse the glycemic control is. However, if you look at the enzyme that tries to maintain the length on these telomeres, it's called telomerase. Telomerase is a magnesium-dependent enzyme. So if we think about telomerase trying to help maintain the length on these telomeres, and that length and telomere being associated with glycemic control, it stands to reason that the better the magnesium status, the better the telomeres, the better the glycemic control would be. So just an additional mechanism for you to consider as well. The next nutrient here being vitamin D. So when we look at what the role of vitamin D is, we're thinking about beta cell function here. And what we're looking at with this is that we're influencing insulin secretion by regulating these intracellular levels of calcium. So predominantly we know that one of vitamin D's predominant roles is it forms these calcium-binding proteins. One of the more popular ones being named calbindin. That helps increase the uptake of calcium from the GI tract, and then that calcium is in turn utilized intracellularly as kind of I always think about these. I explain these things, calcium as being a light switch for the cells. That's how I explain that to my patients, and I let them know that calcium is this intracellular stimulator. It turns things on. It turns on the metabolic processes. And then vitamin D also has the role of increasing beta cell resistance to apoptosis. So it keeps these beta cells around for a longer period of time and helps maintain some of the integrity of the pancreas itself. This is just an example of looking at vitamin D as a predictive marker. Just note the title on this particular study, and that will vitamin D become a new anti-diabetic. So we can just simply extrapolate from this that the lower the vitamin D status, the greater the likelihood of developing some type of dysglycemic state is going to be. And to further that point a little bit more so with biotin having the same type of role, and you'll see in this particular study that our results suggest that biotin deficiency promotes hyperglycemic mechanisms such as increased glucagon concentration, decreased insulin secretion, and sensitivity to compensate for reduced blood glucose concentration. So just again, additionally saying here that if that nutrient is not in place, that the likelihood of developing this glycemic profile is increased. Now, moving from dysglycemia into adrenal fatigue. So when we talk about adrenal fatigue, literally what we're talking about here is an increased demand for steroid hormone production. And you can think about adrenal fatigue, and certainly if you think about some more of the more classic models on this, you're looking at categorizing different stages of adrenal fatigue, maybe even going into adrenal exhaustion. You'll have, depending on what sources you read, anywhere from 3 stages to 7 stages on this. We're not really trying to use this to characterize the adrenal states in any way. What we're really trying to do here is utilize this information to help us better understand the stress state that the individual is particularly in, and how severe that is, and how far-reaching the effects of that are in other systems in the body. The way that we go about doing that is through looking at this collective of nutrients here that you're going to see on the slide, and we start this process off with B5. And B5 is, I always think about B5 as being that lead nutrient into steroidogenesis. So when we're looking at trying to form these steroid hormones, that process doesn't take place without take place endogenously without B5 initially being there to help promote that process. We'll look at this on the next slide. But one of the things you'll see is that, and one of the ways you can think about this is that as individuals move further into a chronic stress state, their levels of B5 are going to continue to decrease. And you can think about that through the context of cortisol, that as cortisol levels are under higher demand, as the body needs more cortisol to compensate to that stressor, whether it's blood sugar fluctuations or whatever the stress response may be, then there's going to have to be an increased movement of B5 down that steroid hormone pathway to continue to support that generation of cortisol. Now, that occurs through the production of acetyl-CoA, and again, I'll show you a diagram to really illustrate all this. The other nutrient that really helps you establish this increased stress or this adrenal dysfunction pattern is going to be serine. And serine has the role of acting as a neurotransmitter within the neurons, but it also acts as a gliotransmitter outside of the neurons. And we typically, when we think about, from a functional medicine standpoint, most of the time when we're thinking about serine, we're thinking about it in the context of phosphatidylserine. So what we're literally, when we think about this, we're looking at this as, if we're seeing a drop in serine, we're thinking about this as the body's inherent ability to try to offset some of the damaging effects of that chronic stress response. And I'll diagram this for you in a minute, but just again, whether this chronic stress response is coming from something that seems innocuous like repetitive exercise, or whether it's coming from just an individual's activities of daily living, just kind of the various stressors that are imposed on them on a day-to-day basis, serine is going to be used in the production of phosphatidylserine to try to help offset some of that. Then you run into, or you'll see vitamin C pop up in these patterns sometimes as well. Just know that that's antagonistic of cortisol. What it's trying to do there is protect the insulin receptors against the downregulation effects of cortisol, so it attenuates that action. It's also involved in the, and just as copper is as well too, both vitamin C and copper are involved in the synthesis of, or in the dopamine beta hydroxylase enzyme, which is needed for catecholamine synthesis. And then lastly, what will help a lot of times too is the appearance of B12 in this pattern. And really where B12 is coming into play is that if you think about an increased stress response and thinking about an individual as in a higher, maybe a more chronic sympathetic response, then that's going to mean that there's going to be less parasympathetic activity in the body. And from a neurological standpoint, that means that there's going to be a reduction of vagal nerve activity down to the enteric nervous system. Subsequently, what that's going to manifest is you're going to get reduced secretion of hydrochloric acid through the parietal cells, and with that reduction in hydrochloric acid, you're going to see, and intrinsic factor as well here, you're going to see a reduction of cleaving off of those B12 from the protein sources, and if that intrinsic factor is not there in adequate quantities, then you're also going to see that that binding of intrinsic factor to the B12 isn't there to take place to help further assimilate that B12 down in the distal portion of the small intestine. So, this is going to be your pattern here. Now, when we look at this steroid hormone pathway, what we're seeing with this steroid hormone pathway is that you'll notice that B5 is the lead nutrient going into this. B5 is what's going to eventually take you into cholesterol production and then move you on down into pregnenolone. And then from pregnenolone, it's really dependent on where the demand is. From a stress profile, we're looking at cortisol, but if there's a need for increased anabolic response, you move into things like your androstenedione, DHEA, testosterone. But B5, just know when you see that going down that there's a strong potential that that's feeding that steroid hormone pathway, and that's one of the likely reasons you're seeing that drop. Now, one of the things I ask my patients at their initial visit is, how's their memory? I want to have some idea of how an individual's memory is, and we know that the more stress an individual is under, the worse their memory is, and we see that a lot of times in terms of short-term memory. And one of the reasons that this begins to manifest is, and you'll notice in this diagram, is you see from the right side here that pantothenate is going to be needed to get us into acetyl-CoA, or to help us manufacture acetyl-CoA. So we've got B5 helping us make that, and then we take that, and through the action of choline acetyltransferase, we're actually combining that acetyl-CoA and choline to then in turn make our acetylcholine, which is what we're going to use and think about in terms of brain speed. It's the predominant neurotransmitter utilized in terms of memory. So as you see that B5 is dropping to increase to support the demand of steroid hormones, just know that the other limitation that's taken place there is that there's an impairment in the ability of acetylcholine to be manufactured, and especially if you're seeing a concurrent choline deficiency with this, then you know that that patient is really limited because they're being affected from both sides, and luckily choline is a nutrient that we have the ability to assess with the reports as well. So, you know, look at this as a potential reasoning that the individuals might have some type of impairment on their memory. Now, when we talked a little bit earlier, a few slides back, looking at the impact of stress and kind of furthering this aspect of memory, not only is there an impairment in the production of acetylcholine to support the generation of that memory, that short-term memory, to in turn go through transneural processes to help you over time make that a long-term memory, but what we're also seeing is you're getting down regulation or desensitization of the hippocampal region as well. Now, our body recognizes that, and as a result, it in turn takes the serine that we see, one of the marker that we see on the test, and we take that serine and we move that serine into the production of phosphatidylserine through these phosphatidylserine synthase enzymes. And you can see from the diagram here, you've got a 1 and a 2 on that, and that can either come from phosphatidylcholine or from phosphatidylethanolamine. Now, something interesting to note on this is that if you're looking at the report and you see a low phosphatidylserine and you see a low serine and you see a low choline as well, then that's a pretty good indicator that these individuals are going to have difficulty producing phosphatidylserine through the action of that phosphatidylsynthase 1, just because they don't have the precursors and the substrates to effectively run that pathway. So that's something to keep in mind when you're looking at how to make your selections for different nutrients. This would be an example where giving serine to this patient wouldn't be the most optimal protocol, but yet giving phosphatidylserine and bypassing the action of this phosphatidylsynthase 1 enzyme would be a better outcome for this particular individual. Looking at an example of the adrenals. So when we talk about adrenals, we tend to think about cortisol, but one of the things we want to think about here too is not just the cortical region of the adrenal glands, but we also want to think about this medullary region in the adrenal glands as well. And this medullary region is where we're looking at the production of our catecholamines. So the epinephrine, norepinephrine, these things that are more geared towards that acute chronic stress response. That said, look at how these different nutrients through the production of these through the production of your catecholamines here. Look at the different nutrients that play a role in this. You'll see B6 in here. You see the vitamin C I mentioned earlier in the location that you see vitamin C here for the dopamine beta hydroxylase. You're also going to see copper has a role in this as well. In the region between your phenylalanine and your tyrosine, and then on and down into your DOPA, where you're seeing the THB and the BHB, that's looking at your tetrahydrobiopterin and your dihydrobiopterin. Those of you that have done any reading or studying looking at various methylation pathways will recognize that folate has a role in that particular cycle there. So, you know, even though we don't typically think about folate as being directly associated with catecholamine synthesis, it is associated with that. Just as further down into this pathway, you'll note that SAMe plays a role in here as well, so just another methylation cofactor in this. So I make the point on this to say that when you are looking at you're looking at your micronutrient report and you're making these considerations for adrenals here, don't just think in terms of cortisol, but also think in terms of these catecholamines, and you can do that through the action of some of the nutrients that were in that diagram, but probably the one that tends to be most diagnostic in that manner is going to be copper. And the thought process you want to have in looking at copper as having a role here is that the higher the more deficient copper is, the higher the likelihood that you're going to have some type of chronic catecholamine secretion. The more likely that epinephrine, norepinephrine, or adrenaline, noradrenaline are being secreted. steroid hormone production is likely impaired, and especially if you're seeing this with a low B5, then you can know that that individual has gotten to the point where they're not effectively, probably even going to the point of managing their glucose through the action of cortisol as a glucocorticoid, but now they're having to routinely dip into their catecholamines to continue to carry that load for them as well. And what this means for us is on a doing observation with our patient, we're probably looking at a patient that tends to have a greater excitatory state. Those individuals that tend to be a little bit more anxious, a little bit more nervous, this is a process you can think through with them. Now the last pattern I want to look at with you here, and this one will be a fairly quick one, a fairly straightforward one, is looking at fatigue, just because there's so many different things that can be associated with fatigue. But if you look at these, looking at the B vitamins, magnesium, CoQ10, carnitine, so some of these are the ones that we more traditionally think about, in that, say, if you picked up a supplement that was an energy-oriented supplement, these would be some of the nutrients you're likely to see in that. But then on the other side over here as well, you've also got ones that are just as equally relevant, but they're just not, in general, talked about as much. So let's look at a diagram here and just kind of see where each of these different nutrients fits in. And I think rather than going through, my feeling on this was, rather than throwing a lot of different slides up here, let's just let this picture say 1,000 words for us on this, because what you're going to see is that with your carnitine here, you've got carnitine that's going to help shovel those fatty acids into the mitochondria to in turn be utilized in the citric acid cycle. And then with your proteins and your carbohydrates, you're looking at your lower B vitamins and your lipoic acid. These are all nutrients that we can look at and assess. Now, once we get down into the Krebs cycle, into our citric acid cycle here, you're going to see some of these same nutrients start to pop up, but you're also going to see the addition of manganese and magnesium, as well as cysteine popping up. So just looking at some of these additional amino acids that play a role in energy production also. And then lastly, moving into that third stage of energy production, where we're beginning to think about the immediate generation of ATP, the predominant nutrient that's going to have a role here is going to be coenzyme Q10. So this is a mitochondrial phenomenon and that's where this is taking place at, is within that mitochondria. So, if we see that CoQ10 is deficient, we can look at that as either an indicator for some type of mitochondrial dysfunction, or the fact that we don't have good endogenous production of coenzyme Q10 because, as this diagram illustrates, we're lacking some of the additional nutrients here, some of these lower B vitamins, our magnesium, manganese, that allow us to be able to make CoQ10 on our own. So, when you're trying to dissect maybe where energy deficiency is, or where energy production is limited at, this is a great diagram to help kind of fast track that process. The comment I want to leave you with on this slide is that the other consideration you can make in here as well, that's not illustrated in here, is that as a part of that electron transport chain, remember what you're also doing in here, and the reason we call this beta oxidation is because we're also burning that oxygen as a part of this energy production process. So to have been able to deliver that oxygen to the cell, we also have to have adequate B12 and folate for healthy erythrocyte production, or healthy red blood cell production there. So just another consideration you can make on this. Now, in summary, and to wrap this up, I want to leave you with 3 points on this. And these 3 points are going to be that while individual nutrient deficiencies are helpful, and you definitely want to look at these individual nutrients, so don't just glass over them and not pay attention to them. Really where our attention needs to be is with the nutrient deficiency patterns, because they offer more insight about the overall state of dysfunction for the patient. And then the 3 patterns that if you can really get a good hold on and master these 3 patterns, you'll have a good working knowledge of the test, is going to be the dysglycemia or diabetes pattern, the adrenal dysfunction, and the fatigue patterns. And then lastly here, use these nutrient deficiencies as predictive markers to help patients understand the need to follow through with care. That's a big one, I feel like, in terms of patient management, because that patient needs to know that this is not just a nutrient deficiency. This is an impairment in their biochemical state, and by not repairing that impairment, by not patching that system back up, the only thing that they can expect to continue to happen further downstream for them is more dysfunction. So they need that nutrient deficiency repaired for them. So, those are the 3 takeaway points I'd like for you to walk away from this presentation with, and hopefully after listening to this, you can take that information and you can begin to fast track these and look at these patterns and say, okay, now I have a good feeling for what's going on with my patient, and I feel more comfortable in the interventions and recommendation strategies that I need to implement with the patient. So I want to thank you for attending the call tonight, and I certainly hope this has been helpful for you. So again, thank you.
Thank you, Dr. Hill. Unfortunately, we are out of time for any questions. Remember, you can always contact your SpectraCell representative or email your questions to webinar@spectracell.com. Thank you and good night.